Welcome everyone to the symposium entitled Increases in Congenital Syphilis, Perspectives from Around the Nation. I'm Hillard Weinstock with the Division of STD Prevention at CDC, and I, along with Ryan Murphy from the California Department of Public Health, will be moderating this session. Today we have 4 15-minute talks. I want to remind you that there will be a live question and answer session for this symposium on Friday, September 18th at 2:30 p.m. Our first speaker is Dr. Ginny Bowen. Dr. Bowen is an epidemiologist in the CDC Division of STD Prevention. She came to the division in 2013 as an Epidemic Intelligence Service officer and stayed on as a staff epidemiologist working on a variety of projects, including antibiotic-resistant gonorrhea detection and response and syphilis diagnostic test evaluation. Her current work focuses on syphilis surveillance. She will be speaking on national trends in congenital syphilis. Dr. Bowen.
Thank you. Good afternoon, everyone. I'm thankful for the opportunity to kick off today's symposium discussing congenital syphilis in the United States. I hope the overview I provide lays the groundwork for the next 3 presentations that you'll hear, which are focused on state experiences. Understanding congenital syphilis, which I might refer to as CS in this presentation, requires that we explore 3 key questions. First, what do we know about reported cases of congenital syphilis? Second, what do we know about the mothers of reported cases of congenital syphilis? And finally, what do we know about reported cases of syphilis among women in general? The case reports of syphilis among women often contain the most detailed information about social and behavioral characteristics. Understanding women with syphilis is one key to identifying upstream interventions designed to prevent congenital syphilis. Let's dive into the first question first. U.S. congenital syphilis cases increased 297% during 2012 to 2018. Congenital syphilis cases are represented by the teal bars on this graph. As I'm sure you've heard before, congenital syphilis tends to mirror the rate of primary and secondary syphilis among women of reproductive age, which is represented by the gold line here. Congenital syphilis was on an upward trajectory when we last reported out on 2018 numbers, and cases are expected to increase again for 2019. As of late July, over 1,600 preliminary reports of congenital syphilis for 2019 had already been received at CDC. This number is already 20% higher than it was in 2018, and the number will not be finalized until late September, meaning it may still increase. Although I'm not quite prepared to show you 2019 cases by state, it's important to see how cases in general are distributed. In 2018, 41 states reported at least 1 case of congenital syphilis. This is up from 31 states in 2012. Case reports are highest in the US South and West. Not only do we want to understand where cases occur, we want to understand how this is changing over time. Let's look at recent history for a moment. Although all regions experienced increases in congenital syphilis during 2013 to 2016, it's clear that the West really began to see CS increases before the rest of the United States. But the South decided to play catch-up beginning in 2017, leading to an overall relative increase of 226% in case reports during 2013 to 18. The West reported the highest relative increase, 509%, during the same time frame. Although it's a little bit hard to discern because of the scale of this graph, it's worth noting that the Midwest saw a doubling and the Northeast saw a tripling in case counts. Did something specific happen in 2016 and 2017 leading to these increases? I don't suspect so. Efforts to address congenital syphilis were scaling up widely in 2017, but in reality, these efforts were in recognition of a problem that was already brewing. Many may remember the Syphilis Summit hosted by CDC, which led to the April 2017 publication of this call to action. And others may remember the rollout of a $4 million congenital syphilis supplement to enhance CS surveillance and epidemiology. But for those that are skeptical, who think that increases in 2017 may actually be an artifact, perhaps due to increasing attention on the problem of congenital syphilis, it's important that we recognize that the most tragic consequences of congenital syphilis, stillbirth and infant death, continue to increase. The red line on this graph represents the number of CS cases that resulted in a death. This number continued to increase as total case count increases, which is an early indicator that what we're seeing is not simply an artifact of surveillance. If you're not yet convinced, I do want to explore this a little bit further. In addition to the most severe outcomes of death, this graphic depicts the number of live-born infants with congenital syphilis who experience signs or lab markers of infection. This number, shown in purple, also increased, along with increasing case counts. But if increases were truly artifactual, we would expect that asymptomatic infants, the teal-colored line, might have skyrocketed, while the purple line remained relatively flat. And that's just not the case here. Taken together, all of these pieces of information imply that what we're seeing is a real increase in congenital syphilis. But why are we seeing this shift or this funny divergence in 2017 in which asymptomatic infants are increasing faster than symptomatic infants? We had a few hypotheses at CDC, one of which has to do with health department overload. That thing that happens when the amount of work at the health department finally catches up and outpaces the ability of its employees to keep up. Maybe congenital syphilis case counts had actually gotten high enough so that medical record abstraction for congenital syphilis investigations had just stopped or became less thorough over time, and infant symptoms were no longer being reported. So in fall 2020, we conducted a surveillance evaluation with a very willing state partner. In this evaluation, a team of trained abstractors examined 50 congenital syphilis case reports as they had been submitted to CDC and compared them against the actual infant medical records. This led to an interesting finding. 25% of infant signs and symptoms had been missed by the original investigation in these cases. These signs and symptoms were not reported to CDC. Now, I know this is one example, one evaluation, but it got me wondering, what might the story tell us if we were truly able to keep up with the increasing demands of congenital syphilis investigation and reporting? If I adjust the number of symptomatic and asymptomatic infants based on the finding of that evaluation, this graph is actually a better representation of what might actually be occurring in the United States. I show you this hypothetical only to help us visualize what we might see if the evaluation is an indicator of what infants really look like, as opposed to what overburdened health departments are able to report at this time. Now, what do we know about the mothers of these reported congenital syphilis cases? Well, to start with, we know that 60% of case mothers were 20 to 29 years old at the time of their infant's birth. Although not shown here, I can tell you that case mothers have gotten older over the past 5 years. The number of mothers in their 20s declined by 5 percentage points, while the number of mothers in their 30s gained the same during 2013 to 2018. This parallels an overall increase in mean age at first birth for women in the US during the same period. Although we often talk about co-infection of syphilis and HIV, when we're discussing men who have sex with men, it's really important to note that fewer than 2% of all congenital syphilis case mothers were living with HIV at the time of their infant's birth. At the national level, racial and ethnic disparities persisted among congenital syphilis case moms. Although we've spent a good bit of time up until now talking about case counts, this graph actually shows, taking into account population size, Black and American Indian Alaska Native populations have the highest rates of congenital syphilis, followed by Hispanics, and then by whites and Asian and Pacific Islanders. If we could zoom in on that time period from 2015 to 2018, we would notice that rates are currently increasing in all racial and ethnic groups. Let's take a closer look at how some of these rates differ across region. The Midwestern race and ethnicity profile appears similar to the national profile, but with lower than expected rates of congenital syphilis among Midwestern Hispanics and higher rates among Midwestern Asian and Pacific Islanders. Congenital syphilis rates among Black mothers in the Northeast are significantly higher than all other racial and ethnic groups there, while the Southern profile reflects high rates among both Black and Hispanic mothers. Rates of congenital syphilis in the West correspond to the racial and ethnic profile that we saw previously at the national level. It is worth noting that the Western region reports the highest rate of CS among white mothers relative to other regions. Moving on to our final key question, what do we know about reported cases of syphilis among women more broadly? Syphilis has increased among both men and women over the past 5 years, but increases in women show no signs of slowing. As of late July 2020, more than 6,000 cases of primary and secondary syphilis have already been reported among women. This number is substantially higher than last year's total of almost 5,000 cases. And we technically still have 2 months before data officially closes, meaning this number could climb even higher. As with congenital syphilis, the West and South are hardest hit by primary and secondary syphilis among women. The proportion of women with primary or secondary syphilis who report drug-related behaviors, such as methamphetamine or heroin use, increased during 2014 to 2018. Most strikingly on this graph is the blue line at the top, which shows that 19% of all primary or secondary cases among women in 2018 have reported meth use in the past 12 months. This finding was really interesting to me, so let's explore it a little bit further. When we examine this by US region, we can quickly see that the methamphetamine train of sorts is not being driven equally as hard or fast by all regions of the US. In fact, the proportion of Western cases reporting meth use is over 32%, while the proportion in the South is 11%, and the Northeast is only 2%. During 2014 to 2018, the proportion of primary and secondary syphilis cases experiencing increases definitely varies by region. Attempting to pull back the curtain just a little bit further, I wanted to explore what's happening within regions, which led to this preliminary state analysis. I want to apologize in advance because some states are white or noticeably missing from this map. Those are states that typically have low female syphilis numbers so as to make their estimates unreliable, or they may be one of several states who report drug use data to CDC in a format that's difficult to interpret for this analysis. That said, when we look at the states that are colored in on this heat map, a really noticeable pattern emerges with pockets of high meth use on the Pacific coast as well as in the Ozark Mountain area. This is something that may just represent a blip in time in 2018, but I'm looking forward to exploring this more in 2019 and perhaps adding additional states to the map. Let's take a step back to the national level for a moment and examine some of the reported sexual and behavioral characteristics from women with primary and secondary syphilis. 53.2% had a lifetime history of an STD, 34.7% reported sex while intoxicated or on drugs, and almost 20% reported sex with an anonymous partner, something that we may not have considered a kind of a classic risk factor in the past among women. Other risk factors that have been called traditional risk factors in the past, such as incarceration and exchanging sex for drugs or money, are a bit lower. We're in the process of looking into this further and exploring this across time and by region to see which factors might cluster together or be changing. I want to move us away from description, trends, and classic epidemiology for a second into discussing intervention opportunities. To do that, we need to explore this final question. Where are we seeing missed opportunities to prevent congenital syphilis? At 28% and 31%, a lack of timely prenatal care and inadequate maternal treatment, respectively, remain the largest contributors to congenital syphilis case status in the nation. Closing these gaps is going to require very different interventions. Although I just presented national numbers, missed opportunities for congenital syphilis prevention vary a bit by geography. The most common missed opportunity in the South and Midwest was a lack of maternal treatment, adequate maternal treatment, while the most common missed opportunity in the West was a lack of timely prenatal care. And although it's not shown here, missed opportunities within those regions varied even further by race and ethnicity. For example, women in the South suffered distinct missed opportunities depending on their race and ethnicity. Black and Hispanic mothers were more likely to lack adequate maternal treatment, while white mothers were more likely to lack prenatal care. A finding that might point to different risk factors in different groups of women with syphilis and different lived experiences, frankly. We all know that Texas isn't the same as North Carolina, just like Idaho isn't California. So these types of analyses need to be repeated again at the state level to really identify missed opportunities and close gaps. Although taking a truly upstream approach, meaning controlling female syphilis, would be the best way to turn off the faucet on congenital syphilis, we know that traditional methods of syphilis control are struggling to keep pace with current morbidity, and innovation is really needed in this area. As you can see on this graph, the rate of disease intervention declined by 9%, while the rate of, while reported cases of early syphilis in women more than doubled. Now it's time to take it all home. I only want you guys to take away 4 key things. I guess I should say that again. If you take away only 4 key things, I would like for them to be these things. Congenital syphilis is increasing in all race ethnicity groups and across all regions of the US. Syphilis among women is increasing in all race ethnicity groups, all age groups, something I didn't show you here, and across all regions. And drug-related behaviors, particularly meth use, are increasing among women with syphilis, but significant regional variation seems to exist. And lastly, missed opportunities to prevent congenital syphilis vary by region, which really reflects who has syphilis in those regions, as well as how those groups may fall through cracks in our public health system differentially. Thank you all very much for the opportunity to discuss this with you, and I really look forward to hearing the next presenters delve a bit deeper into their state level information.
Okay, our next speaker is Dr. Shaquetta Johnson. Dr. Johnson is Deputy Director of Operations with the Louisiana STD HIV Hepatitis Program. In this capacity, she is responsible for assisting with the oversight of statewide STD, HIV, and viral hepatitis program activities, and offers program-related clinical consultation to internal and external partners. She has more than 18 years of experience with the Louisiana Office of Public Health. She will be speaking on successes and challenges in congenital syphilis, the Louisiana experience. Dr. Johnson.
Thank you, Hillard. And thank you all for the opportunity to share a little bit about our successes and challenges in Louisiana. We're always grateful for an opportunity for others to hear about the work that we do, as well as learning from each other. So we'll jump right into the presentation. Just taking a look overall at our STI and HIV rankings in Louisiana, it gives you a little idea of how we relate to other states across the nation. You'll see that we, in 2017, were in the top 3 in the country for all of our STIs. And in 2018, we realized that we saw a decrease in not just the ranking, but also in our number of congenital syphilis cases. But we continue to see high numbers of primary and secondary syphilis, gonorrhea, and chlamydia. Dr. Bowen touched on how our national rankings continue to increase with regards to congenital syphilis rates, but you see that in Louisiana, our rate is significantly higher than the national average. And if you look at our overall case count, we did experience a decrease in 2016 and 2018, and that was a result of some very concerted efforts. I wanted you to have a snapshot of how our state is divided amongst our Office of Public Health regions, because I'll make reference to those later in the presentation. And I want you to pay close attention to Regions 1, which is New Orleans, Region 2, Baton Rouge, our capital city, Shreveport, Region 7, as well as Region 8, which is our Monroe area, and Lafayette, which is Region 4. In past years, we saw that many of our congenital syphilis cases were concentrated in our more metropolitan areas, in New Orleans, Baton Rouge, and Shreveport. But in 2018, there was a broader distribution of cases, and we saw that there was a case reported from each of the 9 regions. So we'll see that our problem is not just among urban areas. There's an issue across the state. And when we take a look at some of the demographics, when we look at our 43 cases in 2018, you'll see that, as Dr. Bowen mentioned as well, there's a significant disparity among African-American women compared to white women when we look at our congenital syphilis cases, with more than 76% of those cases being among African-American women. Our women with CS cases were young, between the ages of 20 to 29. But we see that we did make some improvements in our prenatal care provision across the state. So the moms were able to access care, but there was an issue that we saw, and I'll touch on a little bit later, that there continues to be an issue with access to timely and adequate treatment. And you'll also make note that many of the births that were congenital syphilis births were covered by government or public insurance. And now I'll touch on some of that with some of the work that we're doing later in the presentation. When we look at our successes, in Louisiana, this has been an ongoing problem. We've had high rates of congenital syphilis in Louisiana and compared to other parts of the country, and we were #1 for many years with regards to our case rate. But in 2007, the Louisiana state law required that every physician attending a woman was offered a syphilis and HIV test at the first exam during pregnancy. And we took that a step further in 2014 with our third trimester testing law. Louisiana now requires that opt-out syphilis and HIV testing is offered to all pregnant women at the first prenatal visit, in the third trimester, as well as at delivery if their testing status is not documented on the chart. And we had established a data sharing agreement with Medicaid, so we really felt that leveraging that relationship would help us target our provider outreach efforts. And so we set up some meetings with our Medicaid staff, and the objective of those meetings was to look at reducing the number of congenital syphilis cases by increasing access to appropriate syphilis treatment and utilizing our Medicaid syphilis testing data to really improve the education we're providing to providers. So we saw in the data that we reviewed that we were doing pretty well with our first trimester testing. Women were getting tested at their first prenatal visit. However, the third trimester tended to be a little bit lacking. So we really wanted to target that particular group in that parameter. And we also had federal and state support in our congenital syphilis efforts. In 2016, we established regional congenital syphilis case review boards, which were made up of central office staff, our CDC assignees, our regional medical team leadership, as well as our DIS. And that really strengthened the communication across those groups. It helped us take a deeper dive into some of those CS cases to identify those opportunities for intervention. And it was a really useful exercise, and they continue now. We established regional STD and HIV task forces in each of the OPH9 regions. And that was an opportunity for public health to engage with our community partners around STD and HIV prevention. And those were some instrumental relationships that we formed to really increase the awareness and engagement of communities around STD and HIV activities across the state. In 2017-18, we were recipients of the CDC's STD app supplemental funding for enhanced congenital syphilis response. And we used that funding to develop an effective CS case management model, which we developed and hired 2 CS case managers in high morbidity regions. That was Baton Rouge and Shreveport. We hired a CS nurse educator to promote provider awareness of Louisiana screening and testing laws, as well as adherence to CDC recommended screening and treatment guidelines. And we hosted 2 congenital syphilis conferences with the help of Denver Prevention Training Center in 2 high morbidity regions as well. That was Baton Rouge and Shreveport. And in 2019, we've developed our SHOT and SHIP Directs program. SHOT stands for our Syphilis Home Observed Treatment Program, and SHIP Directs is our bacillin to provider program. And SHOT was piloted in regions 4, 6, and 7. That was our Lafayette, Alexandria, and Shreveport regions for pregnant women and their partners. And eligible partners had to have a history of no penicillin allergy. And for pregnant women, they could not have had a history of complications with the pregnancy. But this program allowed our OPH nurses, or Office of Public Health clinic nurses, and a DIS to actually go into the home and provide syphilis treatment to the pregnant woman and her identified sex partner. So this was to mitigate some of the issues we had found in our case review findings, that there were issues with transportation and scheduling, as well as childcare issues. We really felt that if we could take the bacillin to the patient, that would kind of offset some of those barriers and facilitate adequate timely treatment. And also what we were hearing from providers across the state is that there were issues with bacillin being very expensive and stocking it on site being cost prohibitive if they did not diagnose a large number of patients with syphilis. So we developed, in conjunction with our OPH pharmacy, the Ship Direct's RX program. And what that program does is facilitate timely syphilis treatment by utilizing disease intervention specialists to deliver bacillin to private OBGYN providers and community health centers that can't maintain adequate stock. And we used state funds to sponsor this program. And this is for non-340B entities. So this has really been an instrumental program, especially during COVID. We've been able to provide 268 doses of bacillin to private providers through the Ship Directs program. So it's been very successful. Now, some of our challenges. We continue to have an increasing number of CS cases across the state. In 2018, we did have a decrease in the number of cases, from 57 cases in 2017 to 43 cases in 2018. However, in 2019, we did see a significant increase in those numbers toward the end of the year. There were several factors that we think resulted in that increase in cases, including a high turnover amongst our DIS at the end of 2019. And we did see an increase in our overall syphilis morbidity toward the end of the year. Our perinatal surveillance supervisor left the program in 2020, and she was very instrumental in developing and helping to implement our CS case management model. And she also supervised our two CS case managers. We ended the funding for our CS nurse educator in July of this year. So that will be a significant gap that we have in the program that we'll try to offset in other ways, but it will again leave a significant gap in our CS prevention efforts. And we only have 2 CS case managers in Baton Rouge and Shreveport, which were hired using those enhanced funds in 2017-18. But we haven't been able to expand that program beyond those 2 regions because lack of funding. Other challenges continue to persist as we found in our CS case reviews. Access to timely bacillin treatment persists as a problem, and late-term infection and reinfection, which Dr. Bowen also mentioned in her presentation, continue to plague us in Louisiana as well. But we hope programs that we've developed, like SHOT and Ship Directs, will help to offset some of those issues. There is competition for limited staff and resources, as well as high turnover rate amongst our DIS field staff. Poverty across the state is a definite issue, not just because of syphilis, but overall. Almost 19, close to 20% of the state almost 20% is the overall poverty rate. And there are health disparities with significant disadvantages noted among people of color. Almost 33% of African Americans in Louisiana live below the poverty line. Louisiana ranks among states, 45th among states in reported births of 15 to 19-year-olds. And we did expand Medicaid in 2016, and by 2018, more than 480,000 adults have been enrolled as a result of that expansion. Louisiana has a largely rural, low population density outside of the major cities. The majority of Louisiana is considered a health professional shortage area or a low-income population designation, and there is very limited access to OB and GYN services in those rural areas across the state. There is poor transportation infrastructure in rural states. There are no bus lines or even taxi service or Uber, ride sharing services. So transportation is a huge issue in some of the rural areas of the state. And STD testing and treatment services were limited as a result of COVID-19. So for now, CS prevention continues. Louisiana Office of Public Health is definitely committed to congenital syphilis prevention, and we will continue to strengthen that partnership with Medicaid, branching off into looking at how their Medicaid case management services can help us with our CS prevention education and adherence with Medicaid providers across the state. We plan to replace the CS nurse educator and add CS case managers if funding does become available. And as I said, we will continue to promote our SHOT and Ship Direct RX programs because we've seen that they've been tremendously successful as well as greatly needed. I'd like to acknowledge Marion Denning, our CS nurse educator, as well as Ashley Hoover, our former Ship perinatal surveillance supervisor. Thank you.
Our next speaker is Mr. James Matthias. Mr. Matthias is an epidemiologist with the Field Epidemiology Unit for the Division of STD Prevention at CDC and is assigned to the Florida Department of Public Health. Jim got his start in public health as a CDC CSTE Applied Epidemiology Fellow, and he will speak on congenital syphilis in Florida.
And so first I'll give a brief overview on congenital syphilis in the Southeast United States and a tale of two epidemics. So I'll start with this congenital syphilis in the Southeast and then move into a deeper dive into Florida and their maternal and congenital syphilis and then wrap it up with a brief summary and takeaways of our talk here today. So as Ginny started a little bit on the whole overview, I'm going to just talk here about the Southeast United States. As you can see from this map here, most of the congenital syphilis in the Southeast is really focused in our two larger states, which are Florida and Texas, as they both have 108 and 367 of our congenital syphilis counts here in congenital syphilis. But if you take our 17 states and territories in the Southeast, which travels all the way from Texas all the way up to DC and Delaware and down to Florida, the Southeast states account for 52% of the reported congenital syphilis cases in the United States. But they only make up 38% of the population of the United States, so they are representing about 1.37 times more cases than their population. So they are disproportionately affected by congenital syphilis than the rest of the United States. And so if we look at our syphilis among women in all stages, I know that Ginny focused a lot on primary and secondary syphilis and how that impacts congenital syphilis, but all stages is really what contributes to congenital syphilis, especially in the South, where a lot of our late or unknown duration syphilis really contributes to congenital syphilis. And when we look at our rates, 51% of our cases are early syphilis, but yet 49% of our late or unknown duration syphilis is what contributes to disease across the South of the United States. And although Texas and Florida contribute many of our cases, the rates are actually much higher in many of our other states like Mississippi and Louisiana and others across the South. So the case count may be higher in some of our larger states, but the rates are actually higher in some of the other parts of the US. But I just want to bring attention that even though we focus on PNS in many parts of our surveillance efforts, in female syphilis, and especially what contributes to congenital syphilis, latent or unknown duration may account for quite a bit of our congenital syphilis, and 49% of our cases, again, are late or unknown duration syphilis, and that really does contribute substantially to congenital syphilis, especially in the South. And then I do want to also focus on the fact that there's a large percentage of heterosexual syphilis here in the South, and it's been here for quite a bit of time. So when we look at the South compared to the rest of the US, 17% of the cases in the Southeast are early female syphilis, are made up of female syphilis cases. And that's higher than the rest of the US, where only 13% of all cases are female syphilis in that. And many of our states, particularly Arkansas, Mississippi, Oklahoma, and West Virginia, a third of all cases are female syphilis. So heterosexual syphilis makes up a substantial burden of cases in the US. So With every part of our 17 states in the South, with the exception of DC, which is not a state, but the US Capitol, heterosexual syphilis is a substantial burden in the South. DC only has about 4% of their cases are female syphilis, but the rest, it's anywhere between 10% and a third of their cases are female syphilis. So although we focus on MSM syphilis being a high portion of our burden, when we're talking anywhere between 10% to a third of our cases are female syphilis, that is a large percentage of our burden. And it may be even higher if we actually start to, again, include our later unknown duration syphilis, which is nearly 50% of our cases, and maybe even higher, because when we look at Florida and including our later unknown duration, our percentage of female syphilis actually rises to 18% of all of our cases are female syphilis. But this is from our Atlas Plus as our source, and they only include early female syphilis, so I couldn't pull this for all of our southern states. But just a reminder that in the South, we do have a little bit higher heterosexual syphilis than the rest of the US, and that may be just another reason to focus on where heterosexual syphilis may be a little bit more of a burden. But now we're going to take you in a little bit deeper dive into what's going on in congenital syphilis here in Florida. So as Ginny mentioned before, that we have a congenital syphilis is increasing in the US, and she used a little bit different time period going back to 2000, but in the last 10 years, there was an over 200% increase in congenital syphilis in the United States. Focusing on in Florida, we had an over 400% increase in the last 10 years. If you looked at 2009, we only had 21 cases. That didn't seem as much of an unmanageable problem at the time. But somewhere around 2015, we went from about 38 cases all the way up to over 108 reported cases in 2018. So that went from a 400% increase in that time frame. And so this is where we're going to start to wonder, well, what happened in this time frame where even going from 21 cases to 48 cases in 2014 seemed like a 200% increase was something we were concerned about. And now there's something that we are very much more concerned about when we went to a 400% increase. And now if we look at the geographic distribution of congenital syphilis in Florida, because in many ways, we highlighted the fact that there were 30 to 40 states now that are reporting congenital syphilis, and how bad it was that there was just one case in some places. Well, in Florida, we don't just have one county that has congenital syphilis. In 2018, we had 22 counties that reported just one congenital syphilis case. So it's not just Miami-Dade or Jacksonville that's reporting congenital syphilis cases. We have 22 counties, and it's widely dispersed throughout the state of Florida. And as a matter of fact, we had now 32 counties of our 67, so nearly half of the counties in Florida reported one congenital syphilis case in 2019, and 9 counties reported 6 or more cases of congenital syphilis. So we are really showing that congenital syphilis is actually quite widespread in Florida, and in many cases, there are several counties now that have a large number of congenital syphilis cases as well. So it's no longer just one county that's dealing with this issue or one metropolitan area that you can say you can focus your efforts on. It has become a much more dispersed problem, and many county jurisdictions have to deal with congenital syphilis within Florida. But when we look only at PNS syphilis among women increasing in Florida, going back to the graphs that are nationally put out, which focused on the United States seeing an increase and mirroring that type of increase, Florida has only seen a 142% increase from 2009 to 2018. So even though we've seen a 400% increase in congenital syphilis, we've only seen a 142% increase in primary and secondary syphilis. So that increase that we're seeing in congenital syphilis is not the same burden that we're seeing in primary and secondary syphilis, because it's not necessarily as easy to identify primary and secondary syphilis, but yet we're still seeing a large increase overall in other stages of syphilis in women as well. But that also leads us to the next thing that I want to bring you to, is that if we look at this graph, we are seeing in the blue bars and the orange bars a large increase in pregnant women in syphilis and overall. So you can see the large increase in congenital syphilis. But if you look at the gray line, which shows our percent prevented cases in Florida, what you can see is around 2013 and 2014, we started to see an increase in the amount of prevented cases in Florida, reaching a high of almost 80% of our congenital syphilis cases were prevented, which meant 4 out of 5 cases we were preventing. So even though in 2014 we started seeing an increase in the number of women with syphilis during their pregnancies. So that could explain why we were still seeing an increase in congenital syphilis and still seeing more pregnancies, and leading to that fact that just because we had more pregnancies, you could have more congenital syphilis. After a period of time, we started to see a decline in the percentage of cases prevented as well as an increase in the amount of women with syphilis during their pregnancy. So it's kind of a double whammy, as you would, that you're having more women with syphilis, but also having less women being prevented with their congenital syphilis. So what I want to now do is look at a little bit more why we might also not be preventing some of these women and where these women may be entering our system of care, or potentially lack of care in Florida as well, and seeing where we're going from potentially where we were preventing 4 out of 5 cases in 2014 to now about 2 out of 3 cases in 2019. And so looking at 2013 and 2014, we did an evaluation with Louisiana in a study on the effectiveness of prenatal screening and treatment to prevent congenital syphilis. And what we really found was that there were about 5 key contributors that led to causes of congenital syphilis in Florida and Louisiana for 155 causes of congenital syphilis. And really the 2 main causes was a lack of prenatal care or no recorded syphilis test, which we took to basically mean, again, a lack of prenatal care, because it was really hard to discern the difference between a lack of prenatal care or someone who had no recorded syphilis test throughout their prenatal care record. And that was about 25% of our cases in Florida and Louisiana. The other part was 23% or women who were screened early in their care, but never got rescreened and were tested positive at delivery. And so that was someone who was likely to have been infected at delivery or late in their pregnancy. And so that was about another third of the women in our cohort. And then when we start getting a little bit lower, we're talking about less than 10% of our women, and that's women who had a 4-fold titer increase during their pregnancy after treatment, which would be indicative of either treatment failure or reinfection. And then another 9% were women who were treated less than 30 days prior to their delivery. So these are women who were identified greater than 30 days prior to their delivery, but did not receive timely treatment. And then there were another 8% who had insufficient treatment for their late or unknown duration of syphilis, which means they did not get their 3 doses of bicillin according to the STD treatment guidelines. And then finally, there were 38 women that had a miscellaneous reasons of causes that accumulated 25%, which could be the mother was, for example, treated sufficiently and the infant had signs and symptoms, and other reasons that were a multitude. And if you want to look, you can look at the paper for the other reasons that existed. But now we want to look at 2019, and this is coming from our Congenital Syphilis Review Board. So this data is not finalized, but we only reviewed 85 cases of our 130 some cases that we were able to look at. So this is also not the full subset of our 130 some cases from 2019, because we only were able to review 85 of our cases. So this may be some of an opportunistic selection as well. Of the 85 cases that we were able to review, we were able to determine that 33 of these cases had clearly preventable or semi-preventable opportunities where the mothers were in care and had missed opportunities. And so that was about 39%. And those were mothers that had delays in treatment initiation that were clearly defined, or missed opportunities for screening or treatment for mothers who were in prenatal care, or inappropriate treatment for their stage or spacing in treatment, where again, these mothers were in care and had clearly defined opportunities where opportunities were dropped or missed by providers or by the Department of Health or others involved in their care. Now, we also had 52 or 61% where there were less clearly defined opportunities for intervention. That doesn't mean there weren't opportunities that could have been further upstream. It's just they were less clearly defined opportunities where it was clearly available. And a lot of these were where a lack of prenatal care were involved. And that's one of the biggest things, even from 2013 and 2014, where we in Florida continued to struggle to have this opportunity where as far as our records and resources, we continue to identify women who have a lack of prenatal care identified, where we cannot identify any prenatal care on their records less than 30 days prior to delivery. Now, one of the interesting things that we have started to identify in Florida is reinfection as defined by serology at delivery and meeting the case definition has become a more prevalent issue in Florida. If you're interested in this, we have another talk about this at the conference, and we recommend that you come listen to this as well. We continue to see birth tourism in a small number in Florida, less than a handful of cases where women will come from the Caribbean and deliver with less than 30 days prior to delivery, and that's contributing to a small number of cases. And then a few of our mothers had an incomplete interview or records obtained, and it made it very difficult for us to determine what the opportunities for intervention was in 2019. Now, looking at some of those slides that Ginny presented, this is just kind of looking at Florida's perspective. I know also in the MMWR that talks about drug use being a contributing factor. In Florida, this is among our reported drug use among pregnant women with syphilis. From 2013 to 2019 or 2014 to 2019, we really haven't seen meth use, crack, or heroin be really reported very strongly among women from 2014 to 2019. 4% was the highest we've seen among meth use, although it is slowly creeping up. This is all stages and all women with syphilis and among pregnant women. And we include all women because we interview all stages of women in Florida. So, and so that's why, and we had 91% of our women were interviewed. And so we feel pretty confident that we have a fairly good handle of this. We also use drug screenings at pregnancies when we do our follow-ups at delivery. And so if we had a tox screen that tested positive, that would have also been included in their interview notes. And we're not seeing a large number of meth, crack, or heroin testing positive at delivery on their tox screens at delivery. So it's not one of the things that we're really seeing in our pregnant women with syphilis at this time. When we also looked at reported incarceration or sex for money or drugs, we aren't seeing that particularly high as well. I will say that we did see a spike in 2018 that was a little bit higher than what we normally see for incarceration. That was at about 13%. However, for the entire time period from 2013 to 2019, the entire time period we saw an average of 8% for incarceration in the past 12 months for our pregnant women with syphilis. And our sex for money and drugs averaged out to 5% for our pregnant women with syphilis. Now, when we wanted to look at partner services for early female syphilis in Florida, this is from 2015 and 2016. One of the things that we want to point out is that this is our named sex partners. Our claimed sex partners is obviously higher than the women who named their sex partners. Of our 1,066 women who were interviewed, 30% did not even name a sex partner. So our disease intervention for those individuals automatically would not have any opportunity to bring anyone to treatment. So that leaves that part already at a minimum of 70% where we have an opportunity for disease intervention. Of our 70% that did name at least one sex partner, 1,028 total named sex partners, or 1.4 per index, were named, but only 237 were brought to treatment on or after the index patient, so that's 23%. I do want to point out that that doesn't mean that interventions weren't occurring for the other partners. 25% of partners were preventively treated, and another 14% were tested negative. I know that doesn't add up to 100%. There are other people who were not located, refused partner treatment, and others that add up to 100% for the remaining partners, but I just wanted to focus on our positive outcomes for our partners here. And finally, I want to bring ascertainment of our pregnancy status for women, because that was another aspect that we really wanted to focus on, because going into 2016, it had gotten to the point where our women of childbearing age, we had dropped to 85% of our pregnancy status. But one of the things we did find by focusing our efforts and reducing that to 98.5% where we were able to obtain pregnancy status, when we did obtain pregnancy status for most of our women, and if we look at our peer-reviewed publication on obtaining this, when we did find pregnancy status that was missing, most of these women, when we resolved their pregnancy status, we did determine that they were not pregnant. So those that we were missing their pregnancy status for, again, they were not pregnant. So if we did find additional pregnancy status, that's probably not contributing to the additional women with pregnancy for syphilis, although it may have contributed an additional 5% in our cohorts for 2017, 18, and 19. So that's likely not contributing to the additional burden on our field staff by obtaining pregnancy status going forward. So what did we find and what did we take away? In Florida, congenital syphilis is increasing, not just in Florida, but in the Southeast and the US. Congenital syphilis is widespread throughout Florida, and it continues to spread to more counties. Syphilis among women is increasing, while the percentage of those prevented cases is decreasing, which is concerning. Most women did not report or have identified high-risk behaviors in Florida. We found that the lack of prenatal care or late prenatal care and missed screening opportunities are substantial in Florida. What we also think some of our takeaways or next steps is that we need to continue to evaluate our contributing causes for these decreased cases prevented in Florida, and these could illuminate these opportunities for improving our case prevention opportunities. We need to continue to refocus our efforts to eliminate gaps identified in preventing cases through our case review boards, because when we do identify these gaps, they do offer opportunities for improvement. But most of all, we need to continue to work upstream to solve systemic issues surrounding prenatal care or late prenatal care for pregnant women and bringing them into care sooner, since that continues to be an issue here in Florida. And I'd like to thank everyone who helped us across Florida for their contributions, especially the DIS and local supervisors who help every day to make this possible.
Our final speaker is Ms. Rebecca Scranton. Ms. Scranton is the STD Control Program Manager for the Arizona Department of Health Services, where she works with her team to monitor trends in STDs in Arizona and uses data to inform targeted prevention efforts. She will be speaking on congenital syphilis in Arizona.
Hello, everyone. So, like many other jurisdictions, we first started to see congenital syphilis rising in 2017 in the state of Arizona. But like other presenters have mentioned, we can't just look at congenital cases in a vacuum. We know that they're the byproduct of transmission occurring in syphilis overall in a lot of other stages of syphilis. So I've overlaid our rates of our cases of syphilis, of congenital syphilis compared to our early syphilis cases, which for the purposes of this presentation includes primary, secondary, and early non-primary, non-secondary stages, because those are the stages that have indication of recent transmission. And what we see is that the rise in congenital syphilis is not nearly as shocking in this context, and we actually started seeing early syphilis on the rise as early as 2014 in our state. So as we had more early syphilis in our state, particularly among persons of childbearing age, so the potential for early syphilis or for congenital syphilis also increased. Okay, so in March of 2018, following a cluster of syphilitic stillbirths and a fetal demise in Maricopa County, we started building out perinatal review boards, like many of the other speakers have mentioned. And in preparation for these review boards, we were working on getting our data cleaned up to better analyze the cases that we were having. And we noticed right away there were 3 primary data quality issues. First, the maternal and congenital data extracts were not linked, and that was a problem because it made it very hard to determine mom, risk factors, and baby outcomes. All that had to be done manually, which is frustrating when you've got 14 cases, very problematic when you've got over 100. The second issue is that even after we were able to link in the mom and the baby data, there were still gaps in our surveillance where we had questions about access to prenatal care that our data couldn't quite answer. So we began to develop a wish list of additional variables that we wanted to collect. And then the third gap is at the time, at 2018, we were not routinely collecting information on prevented cases. So not only was this a missed opportunity to be able to explore the differences between moms that deliver a prevented CS case and moms that deliver an actual CS case, it was also a problem because we didn't QA review the ones that were closed out as prevented. And when we started to look at them, unfortunately, not all of them really were prevented when we took a closer look at the case definition. So that was a problem. By the middle of 2019, we were able to close all 3 of these gaps. We now have linked mom-baby extract data, so we can do all that analysis through SAS and not manually, which is great. We also have our DIS regularly filling out both the prevented cases and the non-prevented cases for the maternal and congenital records. Gives us better data analysis, more timely QA review of the cases that are both prevented and not prevented, which is helpful. And we have expanded our interview record and forms for collecting those enhanced variables for congenital syphilis. All of this work laid the foundation for us to apply for grant funding through ELC to be able to support 3 new perinatal caseworker staff to provide further support to our growing burden of congenital syphilis. And it also enabled us to apply for funding to pilot test perinatal screening and rapid treatment in the ER setting, which had been identified as a missed opportunity for women not in prenatal care, which was a chunk of our cases. So the other thing we were combating, in addition to improving our data quality, was we were fighting the rise of syphilis on 2 fronts. So we had this really heavy concentration of cases occurring in Maricopa County, which is that bright red dot on the upper maps for our case counts. But when you look at the rates, you can see that we're starting to see this really intense spillover of cases into our rural jurisdictions. And unfortunately, because Maricopa has a long history of combating syphilis, they've got a lot of safeguards to protect against syphilis transmission and congenital syphilis in their community. But those safeguards didn't really extend to the state as a whole. One such measure they had in place in 2017, and actually for years prior, is they had a board order for 3rd trimester testing. That did not extend to the state as a whole. But every 5 years, we get an opportunity to make recommendations for changing the Arizona Administrative Code. And because we were looking at what was going on with our early cases, we knew congenital syphilis was going to be a problem. So well in advance of the implementation of this policy change, we actually made the recommendation to extend the practice of 3rd trimester testing and testing at delivery to the state as a whole. Now, uptake to this new measure was not immediate. It took a lot of work. We partnered with our Medicaid agency, and we also did a lot of traveling of the state to provide education to providers and case investigators about this new policy initiative to help increase uptake to 3rd trimester testing. So as I said, rural Arizona, not as much historical case volume of syphilis, certainly not as much historical case volume of congenital syphilis. So we had a lot of providers and investigators who we wanted to train and build expertise. Unfortunately, we're a home rule state, which is great. It works for our state. But unfortunately, our program has been in a hiring freeze for years. And at the time, we only had 2 epidemiologists. So there really was no way for them to cover all these outbreaks that were popping up in rural Arizona. And we didn't really have the option to expand our staff at central office. So we had to work within the existing resources, and we have some really awesome local health partners that helped us achieve this. So we traveled the state, making sure providers were aware of the new change, aware of the local data for their jurisdiction. Sometimes there was this attitude that, oh, congenital syphilis is a Maricopa problem, which is true, but it's also a statewide problem, and it's certainly a problem in many of our rural communities as well. So we wanted to build awareness about that, awareness about 3rd trimester screening, and also build some expertise around clinical management of these cases, because many of these providers didn't have as much experience working these cases because of historically low case volume. So in addition to training our providers, we were also working to train our local investigators. And again, low historical volume, not a lot of rural counties have dedicated STD staff designed to do syphilis case investigation. So we worked with what we had. We had some awesome PHNs who were doing a lot of other different things. So they bravely took on this new task of doing syphilis case investigation. We also have a lot of tribes in rural Arizona. So when syphilis spilled into rural Arizona, it then impacted more and more tribes in Arizona. So we had some amazing, again, sometimes they had DIS dedicated to STDs. Sometimes we had to work with an IHS facility or a 638 facility to get their public health nurses to perform this function. It really varied depending on what the community needed and what the community had available. But we worked on providing training in disease knowledge, partner investigation, partner elicitation, definitely stressed confidentiality, especially in these really small communities where a lot of people know everybody. And we also talked about internet partner services and how to go about finding partners that maybe don't have a last name or have some username, how to use those internet partner services skills. And then we also expanded access to our database, PRISM. which was really important because we had, prior to the 2017 outbreak of our congenital cases, we only had one tribe on PRISM. We now have 6, which is really great because it means we have near real-time data on their cases as they're being investigated. So we're able to help our tribal partners get those cases investigated faster, do higher quality investigations, and give more near real-time feedback on what areas could be improved upon and what areas are doing really well at. So that's been very helpful. And so it kind of ended up that 2019 was looking super good. Like, we had our really robust surveillance data. We had standardized a lot of our training modules. We had a bunch of continuous quality improvement measures in place. We really wanted to focus on getting more timely investigations to really help cut the spread of disease transmission. We had a lot of new focused congenital syphilis projects on the horizon that were funded through our ELC grant. But then 2020 happened, and our lives changed, and the lives of all of us around the nation changed. We started to see COVID increasing in Arizona around the end of March, running up through June, which also happens to be when we started to see a drop in STI monthly case reports. And we heard some anecdotes of some of our STI clinics doing temporary closures because they're at the front lines of COVID response. In spite of decreased screening and reporting, we're still seeing increases of about 14% in primary and secondary syphilis and about 9% in gonorrhea. So we suspect that transmission continues to be on the rise for syphilis in spite of decreased access to screening and subsequent treatment, which is problematic. Additionally, we're hearing reports of increased persons experiencing homelessness, job loss, food insecurity, all those really heavy things that put people at risk for adverse health outcomes, including STIs. And we've heard cases of women not seeking prenatal care because they're worried about exposure to COVID in the clinical setting. And we haven't been able to do partner services investigation on jailed and incarcerated persons since March, which has really limited our partner services. And some of the press around contact tracing and the misinformation about what contact tracing is has also proven a barrier. Clients can be a bit more reluctant these days to talk about their partners. And of course, one by one, our local and our state STD staff were pulled into COVID. We had to scale back our already thinly stretched resources. Our state is now supporting pretty much all of our rural counties in their investigation efforts, which our program was never designed to do. And unfortunately, in addition to supporting our rules, our state staff are also spending between 33 to 95% of their time on COVID. So a lot of our high priority cases are starting to fall through the cracks. And our program, like many across the nation, was facing some pretty tough choices. Which brings me back to this graph. So even if COVID hadn't delayed a lot of our really cool congenital syphilis projects, we still kind of have this really big problem with early syphilis rising in Arizona. And we know that it's continuing in 2020 based on what we're seeing in our primary and our secondary cases. So we knew we were going to have some unspent funds from canceled conferences and staff turnover and declines in screening. So we started to think about ways that we could reallocate our resources to better contain the larger issue of syphilis in our community, and also to switch up our response to how we were handling congenital syphilis during COVID. So we're right now, because we can't cover all areas, we're trying to focus on those high and medium morbidity areas, trying to prevent further spillover into those rural jurisdictions. We're working very closely with our HIV partners. So when we get a case who's co-infected with HIV, we just pass them on to the HIV program manager, and he's awesome. So he's also helping out our locals, and he ends up taking on that investigation if the county can't take it on, which frees up more of our time to continue working these really important congenital cases. Since we know we're not going to meet our screening targets for 2020, we're also working on a proposal to flip our unused safety net service funds to expand our existing HIV home test kit programs to include STI testing. Again, we're trying to focus those efforts on the areas of high morbidity to help reduce some of the spillover that we're seeing. And we've reworked some of our QA processes to be more in line with what's realistic given the times, and to also be more automated, so that way my staff have more time to spend with clients and doing their important partner services work. Although many of our CS projects have been delayed and scaled back due to COVID, we have had some really great programs that are sustainable even during these really, really tough times that I wanted to highlight. We're continuing to do our vital statistics cross-match on a monthly basis. And we're also continuing to do a cross-match of our mom and baby cases to look for unattached moms and babies. And both of these measures help us find women and babies who fell through the crack who need to be relinked to treatment. We've also been a bit more proactive in linking women to treatment, especially as clinics are closing. Some of the options that were available to them for treatment are not available right now. So we've been really proactive about getting them linked to services. We did delay substantially our implementation of our perinatal caseworker projects and our ER screening project, because those are all contingent upon contracts to be approved, which used to take 3 months. Now it's taking a year, which is not great. But those are getting to the end of their limbo period. So once those are filled, we'll be able to resume work on our perinatal caseworker projects. We did post our ER screening RFP, but ERs are a little bit busy these days, so there hasn't quite been a lot of attention on that. We're still optimistic though, because it would be a very cool opportunity to help catch some cases that fall through the cracks. And yeah, so now more than ever, we are facing a lot of unknowns with congenital syphilis in Arizona, but STD control programs have a very long history of overcoming some impossible challenges. So we're going to continue to grow and adapt our program to meet the needs of our community. Thanks so much for including me in this year's conference. I look forward to learning from and working with you all. And I want to give a huge shout out to all of my EPI staff and my DIS staff who have been doing an awesome job serving the community.
I want to thank all of our speakers today and the audience for your attention. Again, we want to remind you that there will be a live question and answer session for this symposium on Friday, September 18th at 2:30 p.m. Thank you again, and this session is adjourned.